but because it's just about the thumb. But it's something that's unique to my practice. It's not something that what the other guys are doing, so I thought it would be a good thing to talk about. And so we'll go over some basics here. The objectives, just an overview of osteoarthritis in general, some of the in the thumb, what the clinical picture looks like, and what some of our treatment options are, how we go through treating these patients non-operatively and then operatively. So joints in the body: hip, shoulder, knee, wrist, and even the thumb. The hand has many joints, and depending on the type of arthritis the patient has, rheumatoid arthritis, the hand is oftentimes more involved in the hands and feet. But what we're going to talk about today is osteoarthritis, regular wear and tear on the base of the thumb. The basal joint is unique in that it's a saddle joint. The way the metacarpal sits on the trapezium, it can move in multiple directions, and then it helps with pinching and grasping for the thumb. Arthritis is one of the #1 causes of joint problems. About 43 million people in the United States are affected by osteoarthritis, and about 1 million people, new patients per year, develop osteoarthritis. 1 in 6 people, or 1 in 3 families will have osteoarthritis. About 50% of the people over the age of 65. And younger people are at lower risk, but still make up about half the population. Patients who suffer from arthritis come in all shapes and sizes. But the biggest thing is, when people lose mobility and independence is when they start to see treatment from us. And when it comes to the thumb, it typically is the ability, they lose the ability to do household tasks such as turning doorknobs, twisting jars, or their work tasks if they have repetitive work where they're gripping and grasping at work. So this is when people tend to come and see us when they're disabled or immobilized, and then we start treatment. So the basal joint is at the base of the thumb, where the metacarpal comes into the trapezium, and there's also a small ligament that connects the first metacarpal to the second metacarpal, and we think that that plays a major role here. So arthritis is the wear and tear of the cartilage. That's what osteoarthritis is. Everyone says, can it affect my other joints? Well, yeah, because you have the same genetics in all your other joints, but it's not one of these diseases that spreads from joint to joint to joint, although it feels like that for some people. When you have exposed bone, that's when you have pain. Cartilage is smooth, it's low friction, it has no nerve endings, so when you have cartilage on the end of the bone for the joint, you have no pain. But when the bone becomes exposed through cartilage loss, you have nerve endings, you have high friction, and that causes pain and irritation of the joint. It's a saddle joint, and that allows for the swiveling and pinching. The basal joint arthritis is more common in women, and it usually occurs after the age of 40. So what are the things we look for in the office, or what are common complaints the patient will have? A lot of pain with activities that involve gripping or pinching, such as turning a key to a door, opening a jar lid, wringing out the dishwash, the dish towel, swelling and tenderness at the base of the thumb. They'll get a big osteophyte or bone spur that'll cause a lot of swelling down there, or a permanent bump. They have aching after prolonged or repetitive use. That's a lot of times people who have problems at work. And then they start to lose some of that motion, and they get progressive disease that worsens over time. In the office, we're going to ask them the questions about what bothers them. We're going to figure out what their activity limitations are. Are they missing work? Are they having problems after work? Are they having to take narcotic pain medications? Some people will have enough swelling in their wrist that they'll get some concurrent carpal tunnel syndrome, and occasionally we'll have to do a carpal tunnel release at the same time. And physical exam, the big physical exam findings for me are a grind test, where I'll take their thumb and we'll kind of grind that joint, and if that bothers them, that's a good sign that that's really what their problem is, as opposed to just carpal tunnel syndrome. So some people, they'll have some pain at the base of their thumb, but they'll have a lot of carpal tunnel syndrome. If they have a negative grind test, we'll focus on their carpal tunnel syndrome. And then we test their grip strength in the office as well. We compare that to the other hand, because really what our goal is to be able to build that grip strength up to about 80-90% of the other side if it's really lacking. So on the x-rays, we're going to see joint space narrowing here. Right, so if we look here, this black line is joint space. If we look up here, we don't see any joint space. We also see white subchondral bone, or right underneath where the cartilage is supposed to be. That bone is white. That's sclerosis. That's a sign of chronic irritation. you'll see bone cysts develop. This person, that little black circle there is a little bit of a bone cyst. We see the bone spurs, and then we see widening of the intermetacarpal space, or between this is the index finger and the thumb. That space widens, and we think one of the reasons why people will develop this is because as they pinch and grasp over time, they start to stretch out or stress that ligament between those two bones, and it adds to more motion in the joint, which causes that abnormal motion, then causes the wear and tear on the cartilage to progress faster. And that's where you get the joint subluxation. There's ways to grade this. Early on, it might just be some subluxation or widening of the joint. They don't look like they have a lot of bone spurs, or the space is still good up here. Then we start to see this joint space narrowing in this view, and then as we move along, we start to see more and more bone spurs form, and then in grade 4 we see actually arthritis of other parts of the joint. So the other side of the trapezium becomes arthritic, and then we see bone spurs and things like that. We use these grading systems to help communicate, but really what's important is the patient's disability. Can they still work? Are they having more problems? Have they responded to not responded to non-operative treatment? Obviously, this one we're not really we're gonna look for other problems. If we just see type 1, want to make sure that it's not we're not missing something else. We don't just blame it on that joint because the symptoms kind of look like that. But if they have grade 2 or 3, and they're having major disability and they can't do their work, or they're having problems at home, then we'll consider surgery if they've failed non-operative treatment. Non-operative treatment includes things like over-the-counter medications, anti-inflammatories, Tylenol, activity modifications. So you'll see different types of, you've probably all seen different ways of assists for opening jars up at home. So we'll go through some of that. Some therapy can be beneficial depending on what grade it is. Bracing tends to be helpful. A lot of people will use a rigid brace. We like to use what I consider more of a functional brace. It's more similar to this one, the one we use in the office, or this one, where it stabilizes the joint, so it limits some of the motion for the patient, but it doesn't make their hand completely immobile, so they can't use their thumb. Because if you can't use, the reason they're in there is because they can't use their thumb because it hurts. So if they can't use their thumb because now it's immobilized or in a big splint, that doesn't really solve the problem very much for them. So that's what we tend to do. Corticosteroid injections can be helpful, and then when all this fails, oftentimes we have to talk about surgery. And this is kind of a neat surgery because there's about 30 different ways to do it, all of which are fairly successful. The old school way was to cut out the trapezium, so it's almost always a resection arthroplasty. There are some implants available, but why put a piece of metal in there? You guys have seen the knee infections and stuff that come through here, so if we don't have to deal with implants, we try not to. We can just take the bone out and pin it in place, let it scar in like that. After a few weeks, take the pin out, and that works very well. That's one technique that's worked well for people. We tend to do a tendon transfer. We take a tendon from the forearm and we'll reroute it through the thumb. Basically what that does is that provides a little sling for us, and it reconstructs that ligament that's stretched out. So the metacarpal now, instead of sitting on the trapezium bone, will sit in the sling. And then we immobilize them and let it scar in for a few weeks. Also, we'll tuck whatever we have left of the graft in there to add as scar tissue or bulk tissue so that the thumb doesn't settle down. That's the technique we tend to use. There's about 4 or 5 different ways you can get your graft. We just use one from the forearm. That's why if you see mine in therapy or post-operatively, they'll have a couple little stitches up in their forearm. That's where we grab the tendon from and graft it.
What tendon?
FCR. Use FCR. After surgery, they're going to be in a splint and abduction for 2 weeks. Then they come into the office. We take the splint down. We look at the sutures, make sure the incision's healing well, and we'll switch them to a cast. Lots of ice and elevation, Tylenol and pain meds they'll be on during that time. And usually these patients, for the first 2 months, it's really painful. So I really stress to them before surgery that you're not going to like me for a little while, but usually at 3 months, almost everyone comes in and says this was worth doing at this point. But the first, especially 2 to 4 weeks, are pretty painful because of the swelling that occurs. So we'll get them in a cast. The cast looks just like the splint, but we will try and leave their thumb out a little bit if we can. It's not the easiest thing to do, but they get a little bit of motion of that joint so it doesn't get too stiff on them. Because some people will have even arthritis of that joint, that if they're immobilized for too long can be kind of stiff. And then at this appointment, we're going to make an appointment for them to see OT so that when they get the cast off, they can get their removable splint the same day. And we use an orthoplast splint, so it's a moldable splint, so it fits their hand in the appropriate position, and they can take it off very easily for showers and things like that. And then they'll start with range of motion. At that time, they'll come in. They'll come in and see me in the morning. We'll get the cast off. We'll check the incision again, make sure they're doing well with their pain, and then they'll have their occupational therapy visit that afternoon. And then they come back in at 8 weeks, and we start strengthening. And usually by 8 weeks, they can touch their thumb to all their fingers, and then we start strengthening the hand. By that time, things are pretty scarred in. Time to put some stress to the thumb. And at the 4th visit, which is 12 weeks after surgery, most people are back to their normal activities. Had a guitar player, hairdresser, all of them were able to return to work around that time. They usually have strength and motion pretty similar to the other side, but they're still working on their grip strength. It's not fully recovered at that time. This is what the x-rays will look like. You can see that that bone is gone now. That's the trapezium. Pretty well stabilized in that patient there. And at this point, if they're doing well, I usually just let them come back and see me if they have any problems, because most people are kind of ready to get back to work and their normal activities. So that's it. Quick talk, but I'll entertain any questions about this or anything else.
I have two. The bumps, osteophytes?
Usually, yeah, it's a big osteophyte or bone spur.
Do you take those off, or do you?
Yeah, you take those off because you take the bone out.
Okay.
So so this bone's gone, right? And on this side, we have to run a piece of tendon. We run the tendon through the base of the bone here, the bottom of the bone. And so we take the bone spurs off so that the tendon can wrap around it easier. So we just take those out too.
Okay. And the tendon in your arm, that just grows back on its own?
No, you don't need it. So
Okay.
it doesn't change the function and the flexion of your wrist. So it's no big deal.
It's extra.
Yeah.
Okay, it's extra.
It's not really extra, but it's not something to keep. So, there's multiple ways of doing that. In my training, we would always take half of it, but half the time those patients would have they would rupture the second half of the tendon, and so they get a lot of forearm pain. So I just take the whole thing so that we can kind of avoid that complication.